This lecture covers the concepts of acid-base balance. Acid-base balance is like every other system in our body. There's going to be a balance. Acid-base also wants to have a balance. When we were talking about electrolytes, there was a balance there. We had a normal range, and when there wasn't a balance there wasn't homeostasis. Fluid needs to have a balance too, so acid-base also has a balance. When we're looking at fluids, they contain an equal number of positive charges, those are going to be your ions, with your negative charges. Balance occurs by matching the rate of hydrogen ion production with loss. If you think of balance like a scale, you want the two sides to be even. With fluid, there also needs to be an equal number of positive and negative charges. When we're looking at pH, we're going to be looking at this balance. And pH, by the way, stands for potential hydrogen. That's going to be a small p with a capital H. And that tells us how much hydrogen is in the liquids or how active the hydrogen ion is. Acid-base balance has to do with matching the rate of hydrogen production with the loss. Just like fluid and electrolytes, it's going to be important to know your ranges here. So I want you to know your normal. And you can see here, it's going to be a little different when we're talking about arterial blood versus venous blood. For our purposes, we are going to focus on the arterial blood. The ranges for arterial blood pH is going to be 7.35 to 7.45. So really, when we're looking at that normal range, that normal pH range of 7.35 to 7.45, we have to have a balance of acid and bases in our body fluids to achieve that. So anything less than that 7.35, anything on this side of the scale, is going to be acidotic. Anything greater than that 7.45 is alkalotic. As far as the venous blood goes, that range is going to be 7.31 to 7.41. And it used to be not in the past that not a lot was done with VBGs, the venous blood gases, but sometimes you're going to see that on a CMP. You might see a CO level in the venous blood. And then there's other times where a doctor is going to order a VBG because it's a lot less traumatic on the patient. They can still get a good amount of information, and maybe the patient isn't critically ill enough to be concerned with their arterial blood gases. It's more that I want you to be aware that it is a thing, but for, again, our purposes, arterial blood pH 7.35 to 7.45. And really, having a normal pH is extremely important because the pH affects a lot in your body. So we can have excitable membranes, nerves, heart, muscles, GI tract, and so on. And we'll get to that a little bit more when we're discussing the different values. So the first thing that we are going to be looking at when we look at ABGs is going to be that pH range, because the pH can tell us if our patient is acidotic or alkalotic. So acidotic is going to be the less than 7.35, and the alkalotic is going to be anything greater than 7.45. So looking at that number is just going to tell us if your patient is acidotic or alkalotic. So now that we know what is going on as far as acidosis or alkalosis, we need to know what kind of acidosis or alkalosis we're looking at. And that's when we start looking at other things in the blood gas results. Now, changes in blood gases, they're going to affect all sorts of things like the shapes of your hormones and your enzymes, distribution of fluid and electrolytes. One of the biggest ones there is going to be potassium. I know we picked on that a lot when we were talking about fluid and electrolytes. This one really has a powerful punch and affects a lot of things, as we know. Membrane excitability is going to be another one, and medication effectiveness. So we really need to look at that when we're talking about medications as well. So really, equilibrium is really important here, and we want that ABG range, again, to be in 7.35 to 7.45. And you're going to hear me repeating that a lot because it's a pretty important range, and you're going to need to remember it. So acids, they are going to be releasing hydrogen ions when dissolved in water. Some examples of that are going to be your hydrochloric acid. Bases, those are going to be binding with hydrogen ions in solution, and an example of that is going to be ammonia. Buffers, those are going to be critical in maintaining normal body fluid pH, and buffers are going to be acids or bases depending on your solution. With acid-based chemistry, we have a couple things that are going to help us determine acidotic or alkalotic. Bicarb, that's going to be your HCO3, is a base that combines with hydrogen ions to make things less acidic. The normal range for this is going to be 21 to 28. So again, 21 to 28. And I just want to put a little side note in here. Generally speaking, with the pH ranges, I've seen those be fairly consistent throughout the different organizations that I have done clinicals at. But every once in a while, you're going to get a range that's going to be different on the bicarb, the HCO2, and also the CO2 levels. But I want you to always use your textbook that is the required resource for the class, because that is what your test questions are going to be written based on. With the carbon dioxide, the relationship between the carbon dioxide, if one increases, so does the other. So if our CO2 begins to rise, we become acidotic. The range, again, here is pretty generalized. We may see some minor differences depending on what facility that you're at, more so with the bicarb than with the CO2. So again, bicarb is going to be 21 to 28. The CO2 is 35 to 45. And you can see here the CO2 range, the numbers really correspond with what's going on with the pH. So I think that one is a little bit easier to remember since the numbers are very similar. So there's a few different sources for your acids. Incomplete breakdown of glucose, that's going to be, like an example of that would be your lactic acid. So lactic acid or lactate, that's going to be a chemical byproduct of anaerobic respiration. That's the process by which the cells produce energy without oxygen around. Lactate is going to be the normal endpoint of anaerobic breakdown of glucose in the tissues. And then you have your proteins. That's going to be your sulfuric acid. So those are proteins and fats. And then your fatty acids, those are going to be your keto acids. So the keto acids are going to be breakdowns of fat. Anytime a cell is destroyed too, keep that in mind, there's acid inside these cells, inside the cells of your body. So anytime a cell is destroyed, whatever type of acid is in that cell is now going to be released into the bloodstream. So those are going to be generally the kind of cells that are in our body, the types of acids, excuse me, that are in our body. Then we have bicarbonate, that's going to be your HCO3. So bicarbonate is our weak base. And our bodies are going to spit out bicarb if we are too acidic, and that is going to be to help buffer that. And this is going to be a pretty major buffer of our ECF. ECF meaning extracellular fluid. So the bicarb itself originates from intestinal or kidneys. So intestinal absorption of ingested bicarbonate into the ECF, and then kidney absorption and breakdown of carbonic acid. So we're either going to be absorbing this in our gut and our GI tract, or our kidneys, but it's going to be our kidneys that are going to regulate this for us. Next, we're going to be talking about acid-base control actions. First of all, we're going to be talking about respiratory when we're talking about controls. We want to talk about how our body controls the acid-base balance. So there are a couple different mechanisms. One of them, of course, is going to be the respiratory system. The first mechanism is going to be to regulate the pH in our balance is going to be our lungs. And that happens pretty quickly. The second one is going to be renal, so our kidneys, and those are going to be quite a bit slower than what happens in our lungs. And those are going to be the two systems that regulate the pH in our body. So breathing is going to be controlling the amount of CO2 in the body, and that's going to happen either by hyperventilation or by hypoventilation, and that's why it is so quick, because we can adjust those things pretty rapidly. And this is going to be for acid-base balances that are going to be metabolic in origin. When chemical buffers alone, like bicarbonate, cannot prevent blood pH changes, the respiratory system is going to be our second line of defense. So what happens when we become too acidotic? We increase our rate or our depth of respirations, and the goal of that is to blow off excess CO2. If we're blowing off this excessive CO2, we can raise our pH, and that is going to decrease our acidity. With hyper, when CO2 levels begin to rise, and that can happen with illness or exercise is a good example, because when we exercise, we release lactic acid. Substances can also cause this. Sleep apnea can cause it as well. The CO2 receptors in our brain are going to trigger neurons to increase the rate and the depth of breathing, and that's going to blow off our excess CO2. When the levels return to normal, your breathing is also going to return to normal. So if you think about exercise, do you breathe fast when you're exercising? And think about what your body is trying to accomplish there. At the opposite end, when we're talking about hypoventilation, if we don't have enough acid in our body, our brain can slow down our breathing. It's going to save that CO2 because it wants to retain it. That's going to increase your CO2 level, and that is going to increase your acidity. So hypoventilation, if your H is too low, the central nervous system senses that and decreases the rate and depth of respirations to increase the level in your blood. And this all, again, happens pretty rapidly. Remember, too, the relationship between CO2 and hydrogen ions. If one increases or decreases, so does the other. So lungs can compensate for acid-base balance of metabolic origin. When we think about metabolic, if we have a metabolic alkalosis or metabolic acidosis going on, our lungs are going to kick in and they're going to attempt to compensate this. So this is going to be respiratory. And the greatest part about this is it happens very quickly. And you're going to see this too in ICU settings. They will actually, a patient that's on a ventilator, they can adjust the rate and the depth of respirations to mimic this effect in our body. So they can mechanically control the ventilation to get this to occur. Okay, and then we're going to talk about the kidneys, which are much, much slower. So the kidneys are going to be another line of defense against pH changes. They're stronger for regulating acid-base balance, but it takes a lot longer for them to kick in than respiratory. So it can take like about 24 hours. And this is because they have to move around bicarbonate. So it's not going to happen quickly like it does in the lungs. So if your kidneys have to form acids and ammonia or move around bicarbonate, it's going to take quite a bit longer as opposed to the lungs that can simply speed up or increase the rate, the depth, or slow it down to control CO2 levels. Kidney movement of bicarb happens in response to increased or decreased acid. With increase, the kidneys are going to reabsorb bicarbonate, and it's also the kidneys are going to make additional bicarbonate, and that occurs in the renal tubules. When the H is low, the bicarb stays in the urine and then is excreted. The kidneys also work to lower pH by converting ammonia, and that is created when protein is broken down into ammonium, which traps the H ions to be excreted in the urine. With the kidneys, they can compensate when the respiratory system is overwhelmed or unhealthy. Think about your patients with COPD. They have an unhealthy respiratory system. Your patients with COVID. So there's a lot of different things that can affect this. The kidneys can compensate for respiratory or metabolic, so they can do both, whereas your respiratory system only compensates for metabolic. When I talk about compensation, I am talking about the body's attempt to correct those pH changes. This says if the pH is less than 6.9 or greater than 7.8, that it is usually fatal. But pay attention when it says usually. It does not state always. These are two different things. Some people will constantly live in an acidotic state. That might be their normal. Just keep in mind that everybody has a different baseline for their pH. So my baseline might be different than yours. Full compensation occurs when either system, and either system's going to be your respiratory or your kidneys. Remember, those are your two things, your two systems that are going to help compensate for pH. So full compensation occurs when either system reacts in a way that restores pH, so it restores it back to normal. Your partial compensation occurs when either of those two systems compensate, but the pH itself remains in the abnormal range. So that's how you can tell if something is fully compensated or partially. So if your pH is back in the normal range, you've got full compensation. If it's still abnormal, that is going to be partial. The respiratory system is going to be more sensitive to acid-base changes, and that can begin compensating in seconds to minutes. So again, this is really fast, and this only corrects for those metabolic imbalances, metabolic only. Kidneys are more powerful, and that results in rapid changes from the ECF in the ECF composition, and the imbalance may take several hours to days. So again, it's not very fast. It takes its time. This can correct for metabolic and respiratory imbalances. So remember, this does both. Respiratory only compensates for metabolic. Kidneys can do both. So again, with compensation, it's the body's attempt to recover from whatever the primary disorder is, so whatever's going on, to achieve homeostasis. Our kidneys and lungs are going to come into play depending on what's going on, and they're going to try to correct it. So again, respiratory, metabolic only, so it can only correct for metabolic, and kidneys are going to do both. Some examples of this. Compensation for the respiratory acidosis. Our body's going to try to retain the bicarb and buffer out the acid. Compensation for respiratory alkalosis. The kidneys will excrete bicarb. So again, for respiratory, it's only going to be the kidneys that are going to kick in for that because the lungs cannot compensate for respiratory issues. Compensation for metabolic acidosis, we're going to increase the rate and depth. That's our Kussmaul breathing. That's when we try to blow off all the excess CO2 and try to balance the pH. So metabolic, our lungs can help with that. Compensation for metabolic alkalosis, the lungs are going to slow down. So we're going to have hypoventilation. And the point of that is to retain our CO2. And I've got some really good videos in the module that help explain that as well. That way you can hear it from more than one perspective. So compensation, your body is attempting to fix the pH by either using the respiratory system, which is faster, and again compensates for metabolic issues only, or the renal system, which is a lot slower and can do both metabolic and respiratory. What kind of acid-base balances are we talking about? So we've got a couple different ones here. We've got metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. Combined metabolic and respiratory, we aren't even going to address this one in this class. That's really complicated and it's hard to decipher, and it's not something that's going to be expected from you at this level. Think of that more once you start getting into MDC3 and MDC4. It'll be something that will be covered later in the program. So acidosis, we're going to talk about acidosis a little bit. So we've got a pH that's low. It's below 7.35. The acid-base balance of the blood and other ECF is upset, and this is by an excess of hydrogen ions. There's too many hydrogen ions, so we're very acidic. That's the acidosis, so less than 7.35. And it doesn't matter at this point if it's respiratory or metabolic, it's still 7.35. So we know that we are acidotic. There's a lot going to be going on in the body to help cause issues of metabolic acidosis. There's trouble with the hydrogen ions or the bicarbonate ions. For our hydrogen ions, what is happening in metabolic acidosis? Our causes are overproduction of H or under elimination. So either way you look at it, we've got too many hydrogen ions, so we're acidic. For overproduction of hydrogen ions, that can happen with diabetic ketoacidosis, also from starvation, hypermetabolism, that overexercise, seizure can fall into that category because you're using a lot of, it's kind of like an exercise type state where you're using a lot of energy. Hypoxia, excess ingestion of acids. Think about your aspirin, your acetylsalicylic acid. That can also cause too much hydrogen ions. So too much is going to put you in an acidotic state. Under elimination of H, Same kind of thing. We've got too much hydrogen because our body is not eliminating it properly. So this can happen with kidney failure. And that's usually going to be the only way that the body is going to eliminate hydrogen ions, is if our kidneys are not functioning properly. So if we're under eliminating H, it's usually a kidney issue. We can have underproduction of bicarb, that's your HCO3 again. And again, kidney failure is going to be a primary cause from that. Also, that can be caused by pancreatitis, liver failure, and dehydration. We can also have over elimination of bicarb, and that happens with like diarrhea. So we talked about earlier about how bicarbonate and how it's produced in the gut. So if you have a lot of diarrhea, we're going to be excreting all of that bicarb out of our system, and that's going to put us into a metabolic acidotic state. The last thing that can cause this is going to be your excessive intake of alcohol. So that can cause that to happen as well. So what are we going to see on our ABGs when we look at metabolic acidosis? So the first thing we're going to look at is this pH. So the pH right there, it's going to be a number of less than 7.35. So it's going to be lower than the normal range. And that's going to tell us, no matter what, even without looking at anything else, that it's acidotic. To tell if it's metabolic or not, we need to look at the bicarbonate level. And bicarbonate, that's going to be the kidneys. So the kidneys are the metabolic part. For metabolic acidosis, our bicarbonate is going to be less than 21. So we have a pH of less than 7.35 and a bicarb level of less than 21. Our PaO2 right here, that's going to be our oxygen. That's going to be normal. Our PaCO2, or partial pressure of arterial carbon dioxide, that is going to be normal or slightly decreased. Serum potassium, we're going to have some hyperkalemia. So the potassium is taken into the red blood cells and then it's released into the bloodstream, and that is going to be resulting in hyperkalemia. So metabolic acidosis, think hyperkalemia, especially if you're taking care of somebody who has DKA, diabetic ketoacidosis. When they come in, they're going to be in metabolic acidosis, and most of the time they're going to have hyperkalemia as well. Great thing about that is the treatment for hyperkalemia is also a great treatment for DKA, which is going to be insulin, because insulin will help lower their potassium levels. So normal ranges again, pH 7.35 to 7.45. This side is where you're going to be acidotic, lower than 7.35. Higher than 7.45 is alkalotic. Then we have our bicarb, 21 to 28. CO2, 35 to 45. And this value right here, that 35 to 45, matches up with the numbers here. Makes it a little bit easier to remember that one. Okay, so respiratory acidosis. In respiratory acidosis, the reason we become acidotic is going to be due to respiratory issues. So we've got an impairment in the respiratory function. This comes from things like COPD, asthma, which is also under that COPD umbrella, chronic bronchitis, pneumonia. We've got some kind of obstruction going on here. So we have patients who have low O2 sats. So our O2 sats, they will decrease. So there's going to be a lot of disorders, a lot of respiratory disorders that cause this problem. Think about your retention of CO2. You could have respiratory depression, inadequate chest expansion. Sometimes that can happen if a patient has a traumatic injury to the chest. Airway obstruction. We've got possibly reduced capillary diffusion in the alveoli. Maybe an asthma exacerbation. COPD, of course. The other things that can cause this to happen, think about your patients that maybe have been exposed to drugs or toxins. They could have a decreased respiratory drive. Maybe they're not breathing very well. They could have a decreased output of CO2. There's a lot of things that can happen. Trauma is another big one. Patients that have chest injuries, even if it's something as simple as a seatbelt injury, a lot of times they don't want to take those deep breaths in. If they have a broken rib, there's all sorts of things that can cause that. Also, other things can happen. We've got GBS, which is Guillain-Barré syndrome, MS, anything that really can cause muscle weakness. As remember, your diaphragm is a muscle as well. Airway obstruction, asthma exacerbation, physical obstruction. If they've got, a blocked airway, that can cause an issue. We've had patients that have had their dentures obstruct their airway. That's why it's really important to have well-fitting dentures. Anything that's in the lungs that really shouldn't be there. So food, that can cause that issue too. So I want you to think outside the box with that, because it's not always just one issue. It can be a combination of things, really. So really anything that can cause the lungs not to function properly, so that's a pretty big category, or under eliminate CO2. So if we're keeping too much CO2 in, we could have a respiratory acidosis. The hallmark of respiratory acidosis is going to be a decreased PaO2 and an increased PaCO2. So in patho, when you looked at PaO2, it's not the same thing as an SaO2. It's not the same thing as your O2 saturation. And they say that 75 to 100 is okay on that. But I promise you, if you have a patient who has a PaO2 of 75, they're not breathing so well. So they're not doing so well. So you need to think about that. So when I talk about a decreased PaO2, could be 88, could be 84, could be 74. There's a whole lot of numbers in there, but pretty much anything below 90 is no good. The lower it goes, the worse it gets. But always, always, always decreased PaO2 with a rising PaCO2, because they're retaining that carbon dioxide. We're not exchanging O2 for CO2. So if the CO2 is still there, if that carbon dioxide is still there, there's no room for the oxygen. No exchange is happening. So we've got respiratory acidosis. What are we going to see with our labs with respiratory acidosis? We're looking at our ABGs. What are we going to see? So acidosis, again, low pH, lower than 7.35. So we have a low pH. We also have a low PaO2 because we have no exchange of O2. Our bicarb is variable. Kind of skipped over that, but our bicarb is variable. But again, low PO2 because we're not exchanging. Our PaCO2 is high. So high CO2 equals low oxygen levels. So low oxygen. Serum bicarb again varies, of course. And then if acute acidosis, serum potassium may be elevated. Maybe. So sometimes it will be. But, and one of the reasons why it's possible, because if there's renal compensation, if the kidneys have kicked in, the serum potassium levels may be normal or even low. So it really depends on your compensation level here. So what you're going to see is a CO2 greater than 45. So signs and symptoms are going to be pretty important here. And I did upload some of those cartoons for metabolic acidosis in your module. So make sure that you check those out because it breaks all of it down. Get a history on the patient, find out what their baseline is, what their normal is, ask what's happened to them in the past 24 hours, 72 hours a week. Make sure that you know what they've been exposed to. If the family is available, speak with them too, because you can see we can have issues. We could be altered. They could have an altered level of consciousness. They could be lethargic. If they're in a stupor, you're not going to be able to get a lot of information out of them. Or if they're confused, the family is really going to be able to help you out with that because they know what that patient's baseline is. We could have neurovascular changes, issues with muscle tone, muscle weakness, deep tendon reflexes. I mean, if you think about a patient that's confused and now they're weak on top of it, think about what your interventions are because we've got to keep those kind of patients safe. So when you're making your care plans around this, you could very easily incorporate a lot of safety issues here. Cardiovascular changes. So we talked about hyperkalemia, didn't we? So think about that because we just covered that in fluid and electrolytes. Everything that is going on with these patients and their cardiovascular system is going to be directly related to that hyperkalemia. So you want to make sure that all of your nursing interventions are geared towards that. Could have some respiratory changes as well. So decreased respiration, rate and depth. We want to monitor that status. Make sure that you're checking in on them, taking their vitals, placing your interventions for those type of issues. They could also have skin changes, and that's going to be for metabolic and respiratory. So this is what these patients are going to look like with acidosis. And with any of these signs and symptoms on any disorder, I don't want you to think if they don't have the symptom, that means that they don't have the problem. They could have partial symptoms, they could have 3 or 4. Sometimes I've seen patients with alterations in pH, they're in an acidotic state, and they may have very little symptoms. Maybe it's chronic for them. So just don't think if they don't have that assessment finding that they're not having that problem because they very well could be. So think about your priorities for this patient. What's going to be the number one issue with these patients? The priority for a patient experiencing respiratory acidosis is what? So hopefully you thought of reduced gas exchange. So we want to think about our ABCs. They cannot exchange O2 for the CO2. So they've got a low O2, the SpO2, that's going to tank. So I want you to think about your NANDAs, your nursing diagnosis. This is going to help you plan your interventions for this patient. So interventions. How are we going to fix what's going on? First, we need to correct the underlying issue. If we don't take care of that, if we don't stop the cause, it's like putting a Band-Aid on it. It's not going to help. We need to stop the underlying issues. If we have metabolic acidosis, we have to figure out what the underlying issue is and correct it. So if we're having diarrhea, give Imodium, right? Did we take too much aspirin? We need to investigate. So that's why asking questions is so important. If it's DKA, treat it. Give them insulin. Bring the sugar back into the cells. Stop breaking down the fat. That'll also help with the hyperkalemia. Hydrate them. Dilute it out. Diabetic ketoacidosis will be covered a little bit more, especially when we get to Module 9. but it is going to be one of the causes of metabolic acidosis. So we're really going to be looking at the underlying cause and treating it. So we need to take care of that issue to put a stop to it. We want to monitor our patient closely. Do we want to make sure that they're on telemetry, those kind of things? If they have hyperkalemia, check their cardiovascular status. Are there dysrhythmias? So we want to make sure that we're taking care of the patient based off of these findings. For respiratory acidosis, how are we going to fix this? Well, first of all, we need to focus on improving their gas exchange. We need to treat any underlying conditions like COPD, asthma, chronic bronchitis, pneumonia. We can give them medications once they're ordered by the provider. O2 is going to be low, so we can supplement for that. We can put them on oxygen. And a lot of times, most facilities have emergency order intervention sets. So you'll be covered for placing your oxygen on your patient as long as you call for a follow-up order. So we don't wait to treat. So place them on oxygen. Pulmonary hygiene, pulmonary toileting, you do not need an order for that. So that's a lot of different things. I want you to think about what that means to you. So we could be having an incentive spirometer, we could be deep breathing and coughing, repositioning, postural drainage, turning. There's all sorts of things that we can do to help those patients. If they can't get good chest expansion from pain, so think about like your patients with like broken ribs or have had open heart surgery. A lot of times those patients don't want to take a deep breath, or even abdominal surgeries. So we want to teach them how to splint so they can deep breathe and cough, give them pain medications. We want to manage that because we want to encourage them to do that. Ventilator support, if it gets severe, we can intubate them. They can change the ventilator settings to help with that. We can increase the depth, the rate. We can put people on CPAP. We can adjust their PEEP. There's a whole lot of different things we can do to help with that. Think about complications, dysrhythmias. Make sure you're watching their fluid and electrolytes. And there's just a lot that goes into this with these patients. These patients can be pretty complex. So that's how we're going to treat or respond to respiratory acidosis. We are going to be maintaining an adequate gas exchange for these people, for these patients. If it gives a range for pH, we want it to be as close to that 7.35 or better as possible. O2 levels, we want those to be above 90. Some facilities will give you a range of 93 or higher, but a 90 is going to be an improvement for them. We also want them to be trending in the right direction. So maybe 90 might not be realistic. Maybe they came in at 78, and if they're at 88, they're trending in the right direction. So we want to get closer to their baseline. Same thing with CO2 levels. If they're below 40, we want them to be below 45 or at least trending in the right direction. So we want to go in the right direction. We want to see improvement. The more severe the respiratory acidosis, the lower that O2 level goes. So we really want to watch those trends with these patients. Metabolic alkalosis. So a little patho here. We have a decrease in free oxygen ion level in the blood, and it's reflected by our arterial blood gas of greater than 7.45. So alkalosis, base, or basic, that's the same thing. So we have a pH level above 7.45. We don't have enough hydrogen in our blood, and that's for one reason or the other, and our pH goes above that 7.45 range, and we become alkalotic. Causes of this, so we could have too much, excessive intake of bicarbonates. Tums is notorious for causing that. It used to be people would take baking soda for heartburn. All of those things can cause a metabolic alkalosis. So we have to be cautious with that. Remember that some medications can cause an acid deficit, like thiazide diuretics, for example. We could have a loss of negative ions. Or we could even have an acid deficit. Too much base, not enough acid. Vomiting could be a perfect example of that. So when we're vomiting, we're losing that hydrochloric acid. It's lost. So think about patients that have NG suctioning. If we're suctioning all of that out, we can become alkalotic and have some electrolyte imbalances as well. Excess cortisol, so hyperaldosteronism, things like Cushing syndrome. I know I said before about patients that are vomiting and have NG suction. They are really prone to that metabolic alkalosis, and that's due to excessive loss of gastric secretions. So all of those things can really lead to metabolic alkalosis. Respiratory alkalosis. Okay, so when you get super anxious, you can start hyperventilating. So you're breathing too quickly. You're blowing off all that CO2. So that's why breathing in a paper bag helps when you're hyperventilating. It helps contain some of that CO2. Just as long as we're not using that as a permanent technique for anxiety. That would be like a short-term fix. Other causes could be improper vent settings. So sometimes we need to adjust the ventilator settings. If we're trying to fix a problem with a patient, say they're acidotic, we might throw a patient into alkalosis. That's why monitoring is so important. That's why we do a continuous assessment on those patients. We may need to recognize a change, call the provider, get more ABGs, and adjust those settings. Other things that can cause this to happen would be salicylates, so aspirin. That can cause two things. That can cause a metabolic acidosis from too much acetylsalicylic acid, or respiratory alkalosis, because we've taken in so much that our body tries to blow it all off and it goes the other way. A hallmark of respiratory alkalosis are going to be ABGs that have a high pH and a low CO2. So what's our pH level? It's going to be greater than 7.45. And what's the CO2? It's going to be below 35. We aren't retaining enough CO2. So the CO2 is our respiratory, and the bicarb is the renal or metabolic. O2 and bicarb levels are usually going to be normal with this. So respiratory alkalosis, high pH, low CO2. Some of this is probably going to look pretty familiar. It's going to be the same for metabolic and respiratory alkalosis. Some of these things you might see for metabolic or respiratory. And remember, we've got assessments from our fluid and electrolyte. So what is Chvostix? So Chvostix, that's when we tap on the patient's cheek, right? So we're looking for tetany. Think of other ways that we assess for tetany. So we want to look for if they're Chvostix sign and their trousseau. And if it's positive, they have tetany. So fluid and electrolytes and acid-base balance, they fit really nice together. So think about all of those signs and symptoms of hypokalemia, hypocalcemia. We could have CNS changes, paresthesias, muscle changes. We just talked about that tetany, so they could have that. So cardiovascular changes, heart rate, blood pressure, respiratory. These are some of the things you might see in alkalosis, whether it's metabolic or respiratory. So how do we fix it? What's the problem? What's causing it? So we want to prevent further losses of hydrogen, potassium, calcium, chloride ions. And how do we prevent further loss of this? How do we keep the body from losing hydrogen, potassium, calcium, and chloride? We want to modify maybe or stop gastric suctioning depending on what's going on with the patient. And how would we do this? Do we need an order for that? What if it's from vomiting? What if it's from medications? We may need to adjust things. We may need to make a phone call and ask the provider, hey, patient's on a thiazide diuretic. What are we going to do about that? Can we switch them to something else? What if the patient's on another medication? There's a lot of different things we need to consider. And if they are on a thiazide diuretic, what kind of recommendations do we have? Are we recommending Lasix? And then what do we need to watch then? Maybe we need to consult a dietitian. Maybe we need supplements. So those are all things that we need to consider with these patients. Okay, last slide. So we've got some videos that I posted underneath your supplemental information, just different ways to analyze ABGs. There's the Rome method, that's the one that I like. There's the tic-tac-toe method, and there's no right or wrong way to do that. You need to use whichever one makes the most amount of sense to you. And then there's some practice ABGs in the module. Otherwise, if you have any questions, make sure to post them to the discussion board, unless they're personal in nature, and then email those directly to me. Have a great week.